Welcome to Your Family's Health, the program that focuses on healthcare issues with unique and different modalities for taking charge of your health today. Experts talk weekly with our continuing roster of guests from around the country and right here in Nassau County to keep you up to date on the latest health issues and trends. Take care of your mind, body, and soul. Spend the next half hour with the voice of Nassau Community College, 90.3 WHPC, and get on the journey to better health.
Hello and welcome to Your Family's Health. My name is Dr. Jeanine Cook-Garard from the nursing department here at Nassau Community College. And today we're going to learn about a program that provides home-based care for frail and or chronically ill patients who have difficulty getting to the doctor's office. And this is called Northwell Health House Calls. Our guest today is Dr. Konstantinos Deligiannidis, their medical director and associate professor at the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. Dr. Deligiannidis, welcome to Your Family's Health on the voice of Nassau Community College, 90.3 WHPC.
Thank you so much.
So I'm just going to first say and hope that you're doing well in light of this pandemic. Has this virus affected you personally?
Not personally, but we just from our staff and from our family perspective, we're doing well. We're still staying vigilant with the masking, and my family is almost all vaccinated. But fortunately, we're all doing well. So thank you.
So tell us a little bit about you and what made you become a doctor specializing in family medicine.
The thing that really kind of solidified why I wanted to be a family physician was when I was little, I listened to my parents talk about their family physician back in their small town in Greece back in the 1950s. And he did house calls back then. As an aside, when I talk about that experience with many of our older patients, they also remember experiencing physicians doing house calls or, watching programs like Marcus Welby, MD, and reading books about doctors doing house calls. And I just love doing the full spectrum of care, and particularly the house calls aspect of medicine. And in my family medicine residency, I like to say I performed house calls 5% of the time, but I love doing it 100% of the time. I had great training in family medicine. We performed office-based medicine, even though we practiced in the hospital and nursing homes, but there was a particular focus of office-based medicine and also home-based medicine. In addition to that, there was a particular focus on communication, evaluating the psychosocial aspects of a patient's care, seeing patients in their whole context, in addition to the medical side of training. And so all of those skills were, important in family medicine, but also important in house calls as well, in home-based primary care.
Yeah, I also enjoyed years ago my pediatrician coming to see me in the home environment. It does something that an office visit doesn't necessarily do. But explain to me what Northwell Health House Calls is. Is it differ from, you mentioned years ago when the physician would come to your house. How does house calls from Northwell, how does that differ?
Yeah, house calls is a home-based primary and palliative care program. We take care of patients who are homebound and frequently bedbound, patients who have what we call advanced illness. And advanced illness patients are patients that have 2 or more chronic medical conditions, and their disease is progressively worsening, and they have frequent complications and debility. We see them in their late stage of their illness, and on average, their life expectancy is about 18 to 36 months. Now, that's different than a chronic disease management type of care, where patients are taken care of for decades, and the goal is to be proactive and maximize longevity. Our patients are more at the late stage of their illness, and the goal is more person-centered planning to balance both the curative and comfort care together. It's not hospice, though, because hospice is more of life expectancy is under 6 months, and the focus is comfort care. This population more needs the curative and comfort care as their late illness or illnesses progress. Kind of like the difference between taking care of patients in the homebound setting versus the clinic setting, I think of kind of 3 fundamental differences. One is obviously location, but it's more than simply being in their homes. It's we see the patient in their true context. When patients come to the clinic, they can give a facade of what life is like. For example, they can choose to say things are fine at home when in fact they're having difficulty in remembering taking their medications, or they're having difficulty with some of their activities of daily living. But when you're in the home, you can see what daily life is like. You can see also what resources they have or don't have, what needs they have, and you're able to see and talk to them about what matters most. The other major difference is time. So often in the clinic, the patient time with the provider is limited. With our program, we're able to devote a lot of time per patient because of all the complexity of the medical conditions we're taking care of, and also we're able to devote time to coordinate care and to have difficult conversations. And that really brings me to the third major difference, which is the communication. Because of the location and the time, we're able to see patients in their true context and have lengthy conversations with them as to what matters most to them. We talk about advanced directives, we talk about goals of care, and we tailor the patient's treatment plan according to their wishes. These conversations, they happen frequently as part of our program because having clarity on these issues is really important.
So the predominant patient that you treat or visit, is it the older adult, or is your service provided across the lifespan?
It's predominantly the older adult. Generally, our patients are over 65 years old. My patient panel, for example, is average age of 80, 85 years old. There are, however, patients who are younger. So we have patients who have ALS, multiple sclerosis, traumatic brain injuries, and they're in their 30s and 40s. Mm-hmm. And we take care of them at the home. But we also have people who are on the older side of the spectrum who have dementia, COPD, congestive heart failure, and diseases like that.
So how does someone sign up for the service? And is there anyone that is disqualified for the service?
In order to be part of the program, we have certain criteria that people have to meet in order to be part of the program. I think the easiest way to sign up for the program is to just call our office line. And our number is, if you don't mind me saying,
sure, please,
is 516-876-4100. And there will be a prompt to be connected to the intake department. And the intake nurses will go through a bunch of different questions and will be able to see if you can be part of the program or not.
So this particular program, how was this program affected by COVID?
I was affected by COVID from an operations perspective, but also from a disease perspective. During the first wave, to protect our patients and our staff as well, we converted over to a telemedicine type of approach. We still remain connected with our patients, but we were predominantly in the telemedicine type of approach. That being said, though, if patients needed to have a visit for something that we needed to see or needed to evaluate in person, then we arranged for the visit to happen with the appropriate personal protective equipment. As the first wave in 2020 subsided, in the summertime, we started going into the homes more and more. And then we started with the second wave doing a little bit more telemedicine, but because of the importance of kind of going in and making the connections with our patients, we often found ourselves more often than not going into the homes as opposed to choosing telemedicine or telephonic type of visits. But in terms of how things were from a disease perspective, it actually kind of varied along the trajectory of the pandemic. So in the first wave, we had definitely a lot of fear of our patients and our caregivers. We also had patients whose either caregivers or aides had symptoms that made them concerned about possibly contracting COVID from them. And then as the pandemic progressed and as treatments like the monoclonal antibody was becoming more available, there was more vigilance about, okay, I'm beginning to have these symptoms. Can I test for it? If I'm positive, then can we arrange for monoclonal antibody treatment, for example? Whereas in the beginning of the pandemic, we didn't even have the testing available for the first wave in March of 2020. That being said, in the spring of 2021, we were able to provide vaccinations to our homebound patients. So we had the Johnson & Johnson vaccine, and we were able to mobilize our clinical team to reach out to our patients. And for those who wanted to get the vaccine, we were able to vaccinate them at the home instead of the family members trying to arrange transportation to get them to one of those mass vaccination sites and get the vaccine elsewhere. So that was a great service that we were able to provide to our patients. And honestly, the efforts are still ongoing. There are people who need boosters. And for those who didn't get the vaccines at the beginning of our outreach, there are still those who still want to get the vaccines, and we're able to offer the vaccines to them at the home.
You're listening to Your Family's Health on the Voice of Nassau Community College 90.3 WHPC. My name is Dr. Jeanine Cook-Garard, and today we're learning about a program that provides home-based care for frail and or critically ill patients who have difficulty getting to the doctor's office. And this is called Northwell Health House Calls. Our guest today is Dr. Della Ginitas, their medical director and an associate professor at the Donald and Barbara Zucker School of Medicine at Hofstra. So does the doctor go to the home to make the visit, or is it more of a collaborative effort that involves possibly physical therapy, nursing, or other specialty physicians who may get involved in the patient's care?
It is more of a clinical team. Our approach is more of an interdisciplinary team. Mm-hmm. We have physicians, nurse practitioners, nurses, social workers, and medical coordinators all involved in the care of the patient. The providers, the nurses, and the social workers all see patients for routine follow-up visits, acute visits, also on discharge from the emergency department or hospitalization. And the reason for the visits after discharge and emergency department / hospital stay is to focus on making sure that the medical treatment plans are updated or clarified, and any education or communication or even coordination that's needed is provided. But in addition to that, you had mentioned physical therapy, and we have partners that join us in taking care of the patients at the home. We partner with home care agencies to provide physical therapy, occupational therapy, wound care, and visiting nurse services. We partner with hospice agencies, home lab services for blood work and urine work at the home, radiology services for x-rays and ultrasounds to be done at the home infusion companies for intravenous antibiotics and intravenous fluids. And we also partner with podiatrists and dentists who come to the home to help the patients with their foot care and their dental care. In addition to that, we also partner with Northwell Clinical Call Center, which provides a 24/7 type of triage they connect with the on-call provider for any urgent issues that arise. And we also have a great partnership with our community paramedicine program. So to talk a little bit about that, the community paramedics are paramedics with additional training in the care of advanced illness patients. So they arrive at the home for various acute urgent issues, and they assess the patient and conference in online medical control physician via telemedicine. And they provide their assessment, and based on the patient wishes and their assessment, the online medical control physician arranges a treatment plan, whether it's a treatment plan that can be performed at the home or transport to the emergency department. So that's an additional service that we provide to take care of our patients in the home.
Wow, it sounds collaborative as well as very thorough. I asked this question, but who would disqualify for this kind of service?
I would say patients who are able to get out of the home. We really focus on homebound and often bedbound patients. I think that's the major disqualifier, if you will. Yeah. We also really focus on adult patient populations. We don't go into the pediatric realm.
So what is the cost for a house call? And is it covered by patients' health insurance?
It is. So the cost of the program to the patient is covered by insurance. The cost of the program is funded by our partnership with insurers and also partly by philanthropy and partly by our performance with the Independence at Home demonstration project. And kind of like to go into the Independence at Home demonstration project, that was a national demonstration project that was created by the Center of Medicare and Medicaid Innovation Center. The main goal was to have practices provide home-based primary care targeting these advanced illness patients. They're measured by cost of care and also quality of care. I won't go into all the details of the quality metrics that are being measured because those are publicly available on the CMS website. But in order to meet the quality metrics, the quality threshold, you have to meet 3 out of the 6 quality metrics. And our Northwell House Calls program in year 6, and those results were posted earlier this year, showed that we not only met 3 out of the 6, we actually met 6 out of the 6 quality metrics, and we reduced the cost of care by about 22%. The neat part about the Independence at Home demonstration project was that it incentivizes practices to focus on both quality of care and cost of care, because it's easy to focus on one and not the other. And it really incentivizes practices to do both. And we're very fortunate to have this interdisciplinary team and this collaborative team that we're able to meet not just quality metrics, but also show a savings as well.
So how new is this care paradigm? Is it new? Have you been doing it for many years, or how long has this existed?
Well, House Calls has been around now for about 10 years, but the home-based primary care practice model has been around for much longer than that. But I think there is more and more emphasis on the home-based primary care model of care. As our patients, as our population is getting older, there is a lot of need for taking care of our patients. And the current model of trying to arrange, a visit in the PCP's office, oftentimes that doesn't work. And, for example, the current state of affair, sometimes it's difficult to find a PCP appointment, and or if you're able to find a PCP appointment, depending on the situation of the patient, it's sometimes even hard to get them into the building, with the equipment, everything that's involved in the transport for the patient. So unfortunately, the current model is family members, caregivers have to take time out of their day to transport the patient to the emergency department. And oftentimes there's a lot of going back and forth from home to the emergency department. Or when they go into the emergency department and they're admitted to the hospital, there can be agitation in the hospital, mental status changes, hospital-acquired infections, and patients end up weaker and sometimes with other medical conditions on discharge than when they went in. And this current model of care needs improvement. And so home-based primary care is a solution to that, where instead of having this scenario of this current state of affairs, we can provide care to the patient where they know the environment and where it's convenient, it's cost-effective, it's meaningful. And patients and their caregivers really love having this as a solution.
So how has your background as a family medicine physician equip you for house calls?
Well, my background in family medicine and the training that I got, I had a lot of training in terms of assessing the psychosocial aspects of a patient's medical care, working in interdisciplinary teams. There was a particular focus on communication and talking about goals of care with patients. And so all of that kind of translated over into house calls and into doing home-based primary care. Not to say that it's exclusive to family medicine, but the training was particularly focused in family medicine, and it made the transition to doing house calls in home-based primary care that much easier.
What would you say is the one thing you want to leave with our audience when it comes down to Northwell Health House Calls?
Well, I think it'll be easiest if I give an example. So a few years ago, I was taking care of a frail elderly woman who was suffering at home from dementia, and her disease was progressing. She became bedbound and started developing pressure ulcers because of her bed and her mattress, and she needed to be repositioned often. When I brought up the need for a bed and a mattress to the daughter, who was her primary caregiver, she had posed a lot of resistance, and I didn't really know why. And so in one of the visits, I just took a lot of time and delved into that a little bit more. What I found out was that she was struggling with guilt that she needed help. She wanted to do everything herself, and because she loved her mom, and it was coming from a good place. And when she was developing her pressure sores, she felt like she needed to try harder. She needed to try harder to prove to her mom that she loved her. And we spent a lot of time kind of like exploring her feelings as to what the bed meant, like, the underlying issue as to what the bed meant. And we were able to help her realize that, she was doing everything that she could, but she just needed a little extra help. And it didn't diminish her love and care for her mom. And at the end, she ended up agreeing to the bed and the mattress, and her ulcers improved. But it brings me to kind of like the take-home message that I repeat this to many of my patients, family members, and caregivers, is that you don't have to go it alone. You reach out to help. It's not a sign of weakness. And it's just helping your loved one get the care and the comfort they need as the disease progresses. And fortunately, we're a service that is able to help, and homebound primary care practices are able to provide that level of help.
That's a good takeaway. Thank you for being here, Dr. Konstantinos Deligiannidis, the Medical Director of Northwell Health House Calls and an Associate Professor at the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. We hope you stay safe and continue to stay healthy, and thank you for being our guest today.
Thank you. It was a pleasure to be part of your program.
This is Dr. Jeanine Cook-Garard from the Nursing Department here at Nassau Community College, and we want to thank you for listening to this week's edition of Your Family's Health.
We'd like to get your feedback on your family's health. Send your comments by emailing them to whpc@ncc.edu. Podcasts of today's show are available on iTunes, Android Podcasts, and Spreaker. This program was produced at the studios of Nassau Community College in cooperation with the Nursing Department. Join us next week for another edition of Your Family's Health on the voice of Nassau Community College, 90.3 WHPC.